Dear friends, ladies and gentlemen, it's really a great pleasure and honor indeed for me to be here on a very special occasion. And the occasion is very well known to all of you. And the occasion is Mission Clot Care. The whole world is working on clot care. Whether we have antiplatelet drugs or we have NOAC or we have a clot lysis or we have other methods which are mechanical methods of taking care of clots. My purpose here today is to discuss with you about the role of NOAC, novel oral anticoagulants. You all are aware of. We use very commonly Rivaroxaban, we use Apixaban, we use Rivaroxaban, and we also use Entoxaban. But in India, we are using basically more of Rivaroxaban and to some extent Apixaban. My focus today is only on Rivaroxaban, available as Flovas, for example. And I must tell you today, in the COVID era, the scope of this drug has increased tremendously because this particular drug, Rivaroxaban, is a factor 10A super antagonist. It has a robust action against factor 10A, and that's how it made it very popular. All the studies which are done in CCS, for example, chronic coronary artery syndrome, is by Rivaroxaban. Even in ACS, so many studies coming up. With Atlas study, for example, is also Rivaroxaban along with aspirin. And CCS is also with aspirin and Rivaroxaban. PAD, peripheral arterial disease, is also by Rivaroxaban. Atrial fibrillation may be valvular in nature or non-valvular in nature, what we call as NVAF, non-valvular atrial fibrillation. One of the most promising indication is NOAC. Even the valvular indication, people are using it. For example, there has been a lot of controversy about rheumatic heart disease and atrial fibrillation. Should we give them VKA or should we give them NOAC? And the answer today is there is so much of data. If a person has got a mild mitral stenosis or a moderate mitral stenosis with atrial fibrillation, we can give Rivaroxaban. We don't need to give drug like VKA, warfarin or acinocumarin. What is the message from here? The message is Rivaroxaban is the first drug of choice in COVID-inflicted coagulopathy. Rivaroxaban is the first drug of choice in non-COVID infected coagulopathy. For example, if a patient has got ACS, it's a drug of choice. If a person has got CCS, chronic coronary syndrome, a lot of data has been available from the Canadian studies. People are using right and left Rivaroxaban low dose, 2.5 mg BD, along with aspirin, 75 milligrams. And in situations like NVAF, atrial fibrillation, huge data is available. And we know India is the world capital of atrial fibrillation. And the prevalence of atrial fibrillation rises as the age advances. It is 2% at the age of 60, 4% at the age of 70, and more than 6% to 8% at the age of 80. As the age advances, ladies and gentlemen, atrial fibrillation rises, which is a very common cause of cardio-cerebral embolic episodes. So if you want to prevent stroke of arterial origin or a stroke which is because of fibrillation, the drug of choice is Rivaroxaban. So I think Rivaroxaban has a huge potential to be used because we can use for prophylaxis as well as for treatment. So if a person has got atrial fibrillation, there is no evidence of any embolism, we can give a long-term Rivaroxaban. It is to be given with the meals Simple dose available as 15 milligrams, 20 milligrams. But so far as CCS is concerned, or even PAD is concerned, like in Compass trial, which is a very popular trial, where we give about 2.5 milligram twice a day. And recently, a lot of data coming up now in a DVT, where we give it prophylaxis as well as treatment. Pulmonary embolism can also be given as prophylaxis and treatment. The dose is slightly higher as compared to what we use in CCS or ACS. The second thing I really wanted to tell, it's very safe, effective, and there is a very good adherence and compliance. There is no incidence of any hemorrhagic risk. According to me, it has a very low risk for a hemorrhage, and no monitoring is required. A very powerful potential. If you do VKA, the real problem of VKA is we need to monitor by prothrombin time and INR. Here, nothing is required. So even the antidotes are available for Rivaroxaban, for Apixaban, as well as for Rivaroxaban and Rivaroxaban. So these are all the powers and potential of using the dress. So indications are enormous. Contraindications are also there. Any patient who has got an eGFR of less than 15, we don't use Rivaroxaban. But 15 to 30, we can use Rivaroxaban. No other drug can be used. All other drugs like Novox are used when the eGFR is more than 30. We don't use it in antiphospholipid syndromes. We don't use it in malignancy. We don't use it in pregnancy. We have to be very, very careful in pregnancy. The only black box warning when a person has got a metallic valve, we should not use this. So the message is very clear, ladies and gentlemen. A time has come. We need to have paradigm shift from VKA to NOAC. And in the NOAC, the first agent of choice is Rivaroxaban today, because of so much of data available in the ACS, CCS, in the patient has got AF, NBAF, and for stroke prophylaxis and stroke treatment, DVT prophylaxis, DVT treatment, pulmonary embolism prophylaxis, and pulmonary embolism treatment. All patients who has got a prosthetic valve, which is thrombosed like tissue valves, where you can use this. The black box warning I already mentioned to you. I think these are all the promising things which I wanted to mention to you. And the morbidity benefits and the mortality benefits are huge and enormous. We had series of programs organized under the academic partnership of IPCA, where we discussed about the Rivaroxaban in detail, and I gave you only a nutshell message that Rivaroxaban is the first NOAC of choice in the patient having clot anywhere in the body, except a patient who has got a clot with a prosthetic valve and metallic valve. Otherwise, this is a drug of choice, and absolutely there are no contraindication except malignancy, pregnancy, lactation. All those things are usual contraindication, or if the eGFR is less than 15. Thank you very much for giving me this opportunity, and I will be very happy if there are any questions, comments, suggestions to this statement which I gave. Thank you.